Welcome to this informal meeting of the Health and Social Care Overview and Scrutiny Committee. Due to the severe weather warning, the Health and Social Care Committee will not be held in person today, and therefore this meeting is being held virtually on Teams as an informal meeting. No decisions are being taken and all items being discussed are for information and consideration. May I remind members that the meeting will be webcast for live and subsequent broadcast via the Council's YouTube site, and that the members of the press and public may record and take photographs except where there are confidential or exempt items. Can I remind officers and guests joining us on Teams today to please keep cameras and microphones off unless speaking, and please use the raise hand button if they want to speak. Second item is appointment of committee and chair, and I'm asking that we note the resolution of the City Council's appointing the committee and the chair. Third item we've got is the election of a deputy chair. As this meeting is not a formal meeting, this item is being deferred to the September committee meeting. Fourth item we've got is apologies. Can I ask members and scrutiny officers if there's been any apologies for today's informal meeting?
Apology from Councillor Paul Tilsley.
Okay, that's great. Fifth item is declaration of interest. Can I ask other members if they've got any declaration of interest today? Okay. Sixth item is the terms of reference, which were noted in the agenda papers as item 6. Just asking that we formally note those. Seventh item is the appointments to the joint OSC committees. So what I'm going to do is to read out the memberships of the joint OSCs because it's actually not on today's agenda. The Birmingham Sandwell Joint Health Overview and Scrutiny Committee will consist of Councillor Mick Brown, Councillor Kath Hartley, Councillor Jane Jones, Councillor Gareth Moore and Councillor Mumtaz Hussain. The Solihull Joint Overview and Scrutiny will consist of Councillors Mick Brown, Councillor Kirsten Curtelli, Councillor Rob Pocock, Councillor Gareth Moore and Councillor Deborah Harris. Is everybody happy with those nominations?
Agreed.
Okay, thank you for that.
Sorry, could I just a matter of procedure for the meeting, if I could just clarify, because the meeting is an informal meeting today, the committee isn't able to make that decision, but having discussed it with Christian, what can happen if those committee meetings need to meet, that decision can be made by you as a chair and a chair's authority acting in between meetings. So for the purpose of the notes today, that isn't a decision that this committee can make, but those members can be appointed by yourself should they be needed to meet before the next meeting in September.
Okay, thank you for that clarification, Fiona, appreciated. The next note is the action number 8, which is action notes matters arising. As this is not a formal meeting of the committee, the approval of the action notes from the meeting on the 29th of March is sadly going to have to be deferred until our meeting in September. I can update on a couple of points from the December 21 meeting, and that is the Birmingham Solihull Integrated Care System. The maps are due to be circulated to the committee to show the alignment between the primary care networks, clusters of GPs and localities. And Carol Herity is going to confirm the timescales for this work. I think we were expecting to have had these available to the committee before today. However, sadly, from what I understand from the scrutiny officers, there's been some complications in terms of getting the work done, so it has been delayed, but they are looking to make sure that's going to get processed as quickly as possible. Then we've got cabinet members update. Dr. Varney is going to be requested to forwarded copies of the Public Health Faith Setting Toolkit to the committee, and that information was emailed to members on the 7th of July, so I understand. Can people confirm they've actually received that? So I understand those have actually been sent out, Gail, is that correct?
Yes, that's correct. It was sent out by email.
Okay. And then the progress against the actions in the Birmingham, Lewisham African Health Inequalities Review will be reported to the committee on the 20th of December. Is that date still the date we're actually expecting it to be done on, Gail?
Yes, that's correct. Yeah, it's come to the 20th of December.
Third point was the neighbourhood network schemes. Members were sent the following items on the 21st of April this year, and that was a copy of the NSS video presentation and a briefing on the community network support officers. In view for members that weren't on at that particular date, I wonder if it's going to be worthwhile resending that to the current committee membership. Could we get that done possibly, Gail?
Yes, I'll do that by no means, yeah.
Okay, that's fine. Then that brings us up to point 9, which is Q4 adult social care performance monitoring.
Chair, I think Councillor Pocock has raised a hand.
Okay. Yes, Councillor Pocock.
Yes, thanks, Mick. On the matter of the boundaries of the PCNs, I want to raise this because we've taken over a year to get nowhere. I'm puzzled why it's so problematic to produce a map of the doctor's surgeries that fall within each PCN. In the Sandwell and West Birmingham CCG, as was, we got a map about 2 years ago, no problems. There's the map. Have a look at it. I'm mystified why it is we still do not have a map, and Carol has obviously indicated there are some problems. Why is there a problem in showing us a map where the doctor's surgeries in particular PCNs exist? I'm puzzled by this. So, Chair, I wonder if you could talk with officers to progress this matter as a priority for us to have at least for our September meeting, and an explanation as to why such an obviously public and transparent piece of information, which I'd have thought was stuck on a website somewhere, and proves to be so difficult to get hold of.
Yeah, I think that's a point well taken there, Councillor Pocock. Gail, as actually Carol indicated what some of the issues were in terms of getting this information available to the committee. And can we just send out a notification that we would really prefer this information is made available for the September meeting?
I can confirm I have been chasing this with Carol, and Carol has said initially they thought it would be an easy piece of work. It's proved very problematic to do the piece of work, but somebody's currently working on it.
Did she give us any indications as to what the problematic issues were?
No, she didn't, and we have been chasing timescales as well. Yeah,
but I think if we can pursue it in terms of, we would certainly be expecting it to be available for the September meeting, and if it wasn't, we'd want to know specifically why it wasn't available for that meeting. Because Councillor Pocock's right, it's been an issue that's been we've been looking for a while.
Yes, certainly I shall follow that up. Yeah.
Okay, so thank you for that, Councillor Pocock. That brings us on to item 9, which is the Q4 adult social care performance monitoring details. I understand we've got Andrew Marsh, who's the head of service operations and partnerships, joining us today, along with Fiona Gabbin, who's the assistant director. We've allocated 50 minutes for this. So Andrew and Marie, will you be doing separate presentations or a joint one?
What we thought might be helpful for committee members, Councillor Brown, was for Andrew to start off by introducing what the new model of early intervention is. I think we had quite a bit of discussion around that at the work planning meeting at Margaret Street last month. So we were hoping, if it's acceptable to committee members, for Andrew to run through the update on the new model of early intervention, which is the old hospital discharge pathway. And then that will help set context to when we run through some of the performance figures. Although, as always, the performance report these are the measures from last year. So the measures up to the end of March. and the measures I ran through at the work programme are the corporate measures now that will be reported. So the measures I'll run through today are the end of the last performance year, which you'll see today, and some of you will be very familiar with, but which won't be the set going forward because the corporate reporting changes each year and they've been updated. But if it's acceptable, I'll ask Andrew to give the update. I think Councillor Tilsley had some particular queries on care centres and things, which I think Andrew will try to cover so we can capture them for the notes, so that Councillor Tilsley can come back to us with any queries, particularly around some of those areas.
Yeah, that would be great. I think, unfortunately, Councillor Tilsley is not able to join us today.
No,
if you wanted to start off, Andrew, if you get. And then once you give your presentation, we'll have a little halt so that members can actually ask any relevant questions.
Okay, thank you, Chair.
Okay, so over to yourself.
Thank you, Chair. I will just try to share my screen.
That's it.
Andrew, I think you're quite quiet. I don't know.
Okay, can everyone hear me okay?
I can do, yes.
Okay, thank you. So just as Maria said, just to take the committee through some changes that's been introduced in terms of how the hospital sector works. So at the start of the pandemic, we had national guidance that effectively set out how, as a local, well, nationally, how health and social care systems should work in terms of discharging citizens from an acute setting. Originally, that guidance, as it said, sorry, just spotted that the screen, I was just sharing the wrong bit of the screen. As it states on there, the original guidance was introduced in 2020 and it was titled the Hospital Discharge Service Requirements. That policy document has since been updated in March of this year and again in July of this year, and it's now titled the Hospital Discharge and Community Support Guidance. Effectively, since the start of the pandemic, delayed transfers of care has been paused in terms of capturing or reporting on that particular data set. So that's been paused. The key changes that those policy documents introduced were effectively a discharge to assess model, a real focus on the principles of home first, and actually health and social care systems working together to commission suitable discharge pathways. The key principles is effectively around discharge to assess. Prior to COVID and prior to these policy changes, in order for a citizen who needs care or support to be discharged from hospital, they would have needed to have a Care Act assessment done and a package of care commissioned and put in place in order for them to leave an acute hospital setting. For adult social care, delayed transfers of care at the time was a measure of how long we took as a local authority to assess someone and to find someone a suitable placement, whether that be a care package at home or a long-term residential setting. Since the guidance I mentioned has been introduced, that way of working has now stopped, and we're no longer routinely assessing citizens in order for them to be discharged from an acute setting. Citizens are being discharged into one of two primary discharge pathways, which I'll come on to in the next slide. And effectively, the work that's happened is health and social care working in unison to actually build discharge pathways out of acute. So for the Birmingham system, EICT, or the Early Intervention Community Team, functions as our pathway one out of the acutes, and our early intervention beds, which, as Maria alluded to earlier are the beds that we use for Pathway 2. And those beds are within our care centres across the localities and also at Moseley Hall and Westheath. If I just give a bit more detail in terms of those discharge pathways, so there are 4 main discharge pathways out of an acute setting. Pathway 0 is effectively for citizens who are being discharged back to their own home and do not require any additional care or support. So the target for the system nationally is that a minimum of 50% of discharges should be via that particular pathway. Pathway 1, as I mentioned, is early intervention community team for Birmingham. And the requirements there is that a minimum of 45% of discharges should be via this pathway. This pathway is for citizens who are returning to their own home, but who require a period of either recovery, rehabilitation, reablement, or an assessment in order to determine their long-term care needs. Pathway 2 is for citizens similar to Pathway 1, but who require that assessment or rehab or reablement to be done in a bedded setting. So a maximum of 4% of discharges should be via this bedded pathway. Pathway 3 is effectively citizens who are likely to need 24-hour long-term care upon leaving an acute hospital, and a maximum of 1% of discharges should be via this pathway out of an acute setting. In terms of how decisions are made that affect citizens leaving the acutes, it is now very clinically driven. I won't go through each of the items on there, but effectively clinicians on a twice daily basis would review these questions, and effectively where the answers are no, then they would need to consider discharging citizens to a non-acute setting. So discharging citizens to one of the 4 pathways that I mentioned in the slide before. In terms of that criteria to reside, the capturing of the data and reporting is very much health-led. So we're not very involved in capturing or reporting of that data. So I wouldn't be able to share that with you today, but just wanted to give some context as to what it includes. So the report, as it says there, is aimed at measuring the timeliness of discharges. So what time of day are citizens who do not meet that criteria to reside in an acute setting being discharged. It also looks to measure the performance against targets. So the measures I mentioned on the previous slide, it captures that. It also captures all the reasons for every citizen who still needs to be in an acute bed. And it also captures the reason for every citizen who no longer need to be in an acute bed, but are still residing in an acute bed. I have spoken to our health counterpart who would be more than happy to come to the committee to update in more detail on the actual measures and provide that if the committee would like to request that. That's the end of the presentation, just to bring the committee up to speed, and I'd be happy to take questions.
Okay, thank you for that. Andrew, we've got 2 hands I can see so far. I'm going to go for Councillor Pocock first and then go to Councillor Moore.
Thanks, Chair. Yes, 3 questions, or 2 questions and a comment. The Care Act 2012 places a legal obligation, as I understand it, for there to be an assessment undertaken in the hospital prior to somebody being discharged. We now have what you call guidance, which appears to override the legislation. So my first question is, how does this work legally? Is the Care Act legal duty, shall we say, or a right for a citizen to be assessed before discharge? Has that been suspended or superseded? And can guidance do that? Secondly, I'm puzzled by these targets. 50% at least should be basically sent home with no support. How can you possibly set that target as a target plucked from thin air? It must surely depend on the care needs of the individual. If 70% of people need some form of care, then care is provided. To say 50% must be sent home without any package of support is bizarre, because it's not a clinical assessment at all. The actual obligation to provide care must depend on their care needs. So I can't see how you can set a target like that. Thirdly, this is probably the crunch issue for me. I have a constituent whose elderly mother was discharged from Good Hope 10 days ago on Friday, the week before last. That lady and her mother have still not had an assessment, let alone any care. She's been discharged from hospital for 10 days. The daughter has had to provide this just home care. Her mother desperately needs care support. But not only is there no care support, there is still not even the assessment. So for me, if we're getting rid of BTOC, which is a measure of the gap between ready for discharge and having had the assessment and gone out of hospital, we should now measure the length of time someone is discharged and wait before there is an assessment and a care package in place. We've just shunted the DTOC in hospitals into basically a delayed package of support for people in the community. I don't see that being measured on this chart, and yet that's the most crucial thing to measure on behalf of our citizens. So, and I want to take up the outside of this meeting and do exactly how this individual case has come about, because this individual case must illustrate a systemic flaw in the way things are currently working. Thank you.
I can respond to the queries raised. So the first is in relation to the Care Act and whether the guidance supersedes it. I think my understanding is that because these are hospital discharge pathways, at that point the assessment is done within those discharge pathways. So the Care Act legislation still applies because someone hasn't been discharged from those pathways. That links on to the third point, I think, which is around people being left without care. I will speak to you outside to hear the individual circumstance and see what we can do to understand what went wrong there. But effectively, the discharge pathways that I spoke about, people will receive care in those pathways. So EICT, if someone's discharged with EICT, they do receive care and they do also receive therapy input. If someone is discharged into pathway 2, that's a bedded environment where they also receive care. And those environments are within our care centres across Birmingham and also at Moseley Hall. So care is provided whilst the assessment is then conducted. In terms of the question about the targets, that unfortunately was set nationally, so it's not something I could elaborate on further up, unfortunately. But I hope I've answered.
Yes, just to highlight the point of the individual case, there is an individual, and to my knowledge, with this 10-day period in which EICT is not available or provided, and neither is anything else, and not even a contact from a social worker to assess that need. So there is definitely one case, but that case would not have occurred had the system been as effective as you described. So we will pick that up later. Thanks.
Thank you.
Okay, thank you. Councillor Moore.
Thank you, Chair. I was going to touch on as to how these targets have been reached, and I appreciate they've been set here, but targets are pointless unless you have any performance data. So I'm particularly curious if we're expecting 45% to be in pathway 0. Well, what is the current pathway 0 referral rate? Because none of that information has been provided, and targets are pointless without the data to monitor it against. And what happens in a scenario where we exceed the maximum? So I think pathway 4 was 1%. What do we do if we need to refer to 2% of people? That do half that percent not get done? What happens in those scenarios?
So if Maria in her update, I believe, will be giving some data on where we are against the pathways, but I can also give some of that now. So in terms of the pathway 0 for UHB, University Hospitals Birmingham, for all of their citizens, pathway 0 figure at last count is around 89%. So it's well exceeding target at present. In terms of what would happen if 2% of citizens needed to go into pathway 3, which has a target of 1, it's actually just a measure of the reality. So if someone did need that care, they would go down that pathway effectively. We wouldn't put someone down the wrong pathway just because of trying to hit the national target.
Chair, if I can add, if we've got actual performance data, can we make sure they're actually put in the reports and not presented verbally? Because that's not very helpful when I go back and have to look at this in 6 months' time, because the data should be there already, not given verbally when someone asks a question.
Did you want to come in there, Maria?
Just to say, hopefully this will help Councillor. The report you have at the end of March, the report going forward, and I shared what those measures would be in our June meeting. They include the pathway 0 and 1 measure, which is the 95% target, which therefore obviously means pathway 2 and 3 are 5%. So that data will be coming to scrutiny each quarter, but we're in that swap over I mentioned at the start of moving from the old measures into the new measures. And because scrutiny and cabinet reports always have a sort of an 8 to 12 week run-in, you haven't necessarily got the figures Andrew's quoting today on the pathways in this report, but they are part of the performance measures that you will see going forward on those pathways.
Okay, thank you for that, Maria. Does that sort of answer your question, Councillor Moore? Or do you want to come back to
Not
question
really,
to Maria?
because I've noticed a tendency that, performance data is just given verbally at these meetings, and this is only the second one I've been to, which is a very worrying trend. If we're going to the efforts of putting together a presentation and setting targets, then the performance data should be included within that alongside it, so I can understand exactly what it is, rather than having to wait later on in the year or have to look at other reports to find that information. I shouldn't have to go to that length when it should be included, so it's easy to see exactly where we are performance-wise against the targets.
Is there any possibility of Maria taking Councillor Moore's point of view on board in terms of putting some information into the quarterly reports as they're actually submitted to the committee, not retrospectively?
Yeah. If it's helpful, Councillor Moore, when we run through the performance report today, if there's performance gaps you feel on that, because I'll run through the full performance report after this item. So once we run through that, if you feel there are areas that you'd like data on that we do collect, then we will of course try and include that going forward. We have to include the measures which are corporately agreed and go to cabinet, but I know in the past we have certainly provided additional details to members of scrutiny.
Okay, thank you for that, Maria. Councillor Pritchard.
Thank you, Chair. Yeah, just a question to kind of clarify my understanding of these discharge pathways. Is it, you mentioned beds in places like Moseley Hall and other locations where people were discharged to, or were put waiting assessment for a discharge pathway. Is that everybody in on your pathways 0 to 3 on that side? Is that everybody, all 100% would go to a setting like that before going home as part of the care assessments, or is it just some, for example, those in the most acute pathway? And if it's just some, how is it assessed that those people go to a setting like Moseley Hall? to decide who has to have some sort of bedded assessment as opposed to an assessment at home or whatever. And is that in itself not an assessment in a hospital setting in order to make that decision? So yeah, just a bit of clarification around that. And I suppose related to that and to some of the previous questions, if you're awaiting an assessment, you are in a discharge pathway, but you're at home or you've been sent home, but you're technically not fully discharged. Is that correct in terms of how somebody will be, like the less acute pathways here? Could somebody be at home and not fully discharged because they're still in discharge pathways, but in terms of the reality, they are at home in that scenario? Is that, again, have I understood that correctly?
Thank you very much. In terms of the first point, it's so not everyone would go via pathway 2, so just some would go via pathway 2. And in terms of the determination as to which pathway someone would be discharged into, it's via the Home First principle. So the principles of Home First is really that everyone should be able to return home with support if needed, and only those citizens who actually require a bedded unit would go down that route. There are clinical criteria that are taken into consideration to help determine that, but not a Care Act assessment at that stage. In terms of the point you made regarding someone who's home, you are correct in that they're still within the discharge to assess pathway, even though they're home, and they would have care and support given to them until the point at which they've either fully recovered, had their assessment, and long-term care put in place. So they would still receive that care and support until such time as they've had their assessment or they've gone through a period of recovery or rehab.
A comeback question, Councillor Pritchard, or is that okay at the moment?
So yeah, I did just to follow on from that. So if effectively, what is it? So yeah, my follow-up really to that is what is the difference between somebody still being in a discharge pathway but at home? So effectively, they are no longer in hospital. They're being moved out of hospital. They've left the hospital setting. But they are technically, in terms of what's on a bit of paper, not discharged. What is the difference between that and what happened before the legislation that Councillor Pocock spoke about in his questions? So what is the actual practical difference between what happened before Social Care Act and now, other than a definition in terms of on paper somebody is discharged then and now they're on paper they're not discharged, but they are in a practical sense in both cases still at home? What other difference is there really in reality?
So the practical difference is in that scenario for someone who would have been discharged home before is a Care Act assessment would need to have happened within the acute setting. Then a package of care would need to have been commissioned before that person could be discharged. And on average, before we implemented this along with early intervention, that could have taken anywhere above 8 days or 12 days, in fact, to go through that entire process. With the process that is in place now, the time taken to be discharged can be on the same day effectively, because we've got that early intervention community team set up and in place, ready to provide care for someone at home. So it's the length of time that it takes to discharge citizens from an acute setting has drastically reduced. So that's the key difference that you can physically see.
Sorry, I think you misunderstood my question and point. Sorry, Chair. Very, very quickly. No, I meant the practical difference between what is happening now and what happened before the legal requirement to do care assessments before leaving an acute setting in hospital. Before Social Care Act put those in place. So not the difference between now and the guidance that came in 2020. I'm talking the difference between now in practical sense and before that previous legal duty, if that makes sense.
Okay, I hope I'm interpreting the question correctly. Forgive me if I haven't on the second occasion. The only difference is effectively then the determination that we have got discharge to assess pathways now and we didn't before, because effectively the assessment still needs to occur. It's a matter of when it occurs in order to still comply with the Care Act legislation. So the difference is purely a matter of when that assessment occurs.
Right. So just for clarity, there is effectively no practical difference now between what was in place before the Health and Social Care Act, effectively, in terms of the state people are in, despite what it says maybe on a piece of paper in terms of whether they're discharged or not. There's no practical difference between that and the pre-legislation days. Is that would that be correct?
Insofar as the way I explained it before, in terms of the assessment processes, where that happened, and the process in terms of how long it took to get people out of an acute setting back home.
Okay, thank you for that, Andrew. Councillor Jones.
Yeah, I'm going to speak now as a former social worker who worked under a system where when someone was in hospital, their individual needs were paramount and they were assessed while in hospital. So what I'm concerned about is this early intervention community team. Councillor Pocock has already said that, you know, he can give you an example where this seems to have broken down, and I'm pretty sure there'll be loads of those sort of cases in the community. So what I want to know is more about this early intervention community team, how it operates, you know, is it understaffed? Because obviously, if they're not operating appropriately, unless you've got family at home who can mop up like Councillor Pocock has, you know, to provide care, what happens then?
So I can tell you how it operates. So without having the details of the specific case, it's difficult to speak to what exactly has happened. But effectively, the journey that a citizen would take is, in terms of that criteria to reside, clinicians on a ward would have determined that they no longer meet the criteria to reside, and effectively they should be on a discharge pathway home. At which point a referral would be made for EICT, and effectively they would have confirmation that that person is ready to be discharged and the care and support will be in place, and confirmation of what time that discharge should be going ahead. So effectively that's the process to get someone out. EICT is staffed with social workers, nurses and therapists across Birmingham Community Healthcare Trust and Birmingham City Council as well. So effectively, that's the way the service operates. So the care prescription would be determined. So the number of calls that someone would need would be determined, and that would be put in place ahead of that person's discharge. So as I say, I can't speak to the circumstances as to what happened in the case that Councillor Pocock raised, but I will speak with Councillor Pocock outside of the meeting just to try to understand what exactly happened in that circumstance.
Okay, have you got a follow-on question, Councillor Jones?
Well, it just seems to me that this is an area of, you know, the social care system seems to be so overloaded and so understaffed that whatever we put in place, and I'm speaking now, I know what it's like to be a social worker and be in this system and have done a fantastic assessment of your clients, and then nothing happens because you have to join a waiting if it's in the community, you're coming out of hospital. I know what it's like. I mean, I've had my mum stuck in a hospital bed because we couldn't get in the past, because we couldn't get appropriate care. And it just seems to me that we don't seem to be really resolving anything. We just seem to be tinkering around the edges. Now, I know the we can't resolve that here, and that's to do with funding and everything. But I'm just a bit concerned, really, that we're not really moving forward. Okay, that's it, really. I haven't really got a question. It's more of a statement. Sorry.
Okay, thank you. Can I sort of thank councillors for their questions today and for the responses from the officers? I think to sum things up, and I know from my own previous experience as a social worker and in terms of my own family, I think that you often do find yourself in a situation where the person's set up for discharge, you're then told information will be received, and then you appear to have a hiatus, sometimes over a week or a fortnight. I remember one case with my father-in-law. So I think people are concerned, Andrew and Maria, that it's going to be a joined up process and there is sufficient capacity within the system to actually pick up people when they're ready to move from hospital into whatever setting they're actually going into. So can I ask you, Andrew, do you think there is sufficient capacity to make those concerns not as relevant as I feel they may actually be?
So I know there is sufficient capacity currently within EICT as a service. In terms of the joined up way of working, and like I say, I can't speak to the specific example. I don't know if that's what's gone wrong on the occasion that's been mentioned, but I will look into that. But that is something that we are constantly exploring with partners, because we have to work as a system. So it's not something that we as the council unilaterally do. So it's working with our partners to ensure that there is seamless communication.
Yeah, okay. I mean, I'm not sort of commenting on the issue Councillor Pocock raised. I just know from my own experience, from my own family, and from experience of residents in my own ward, that this is an issue that's cropped up fairly regularly and over an extended period of time. And I just want to be sure that moving forward, we're not going to continue down that same path of having those communication and capacity issues. So thank you for that. If we move on then to your presentation, Maria.
Thank you. And firstly, I'll pop on screen the performance measures. I appreciate we've had a really good discussion and taken up a good bit of our slot, and I think I've had to send a note yesterday to the organisers for scrutiny, just to mention, because we're in emergency planning for the heat wave, I'm a cell lead for the city, so I will need to drop off the call at 11 with scrutiny's permission to go into the emergency planning response call.
Okay. In view of that, Maria, could I ask you, because I think we're at 11:45 now, if I ask you just to get through your presentation possibly within 5 minutes, which will give members the opportunity to ask any relevant questions they've actually got. So if you could just sort of skim through it for people.
Will do, yeah. So the main focus for members probably is the first page of this scorecard. As I mentioned to you, at the work programme, we went through an overview of the measures which are going to be reported or are being reported since April. What you've got here is the last run of the old measures that we were asked to provide corporately. So what this is, we do a monthly update that's summarised into a quarterly update that goes to Cabinet and scrutiny about the key performance areas and our performance against each of those measures. The targets that you can see in column 3 are agreed corporately and with the elected member each year. And at the next time I come, you'll see the measures which have replaced these since April. Many are the same, but some have been altered to reflect where we are now in the programme of delivery of adult social care. So I'll focus on this first page. The second page outlines other measures that we keep as a directorate, quite a few of which are on pilot areas. And then behind that is more detail on each of these measures individually. But the sort of highlight summary is this page. So as a directorate and a council, we're very keen to promote user choice and control of their care. And one of our indicators around this is the uptake of direct payments. We're one of the strongest performers nationally for uptake of direct payments, with a really ambitious 40% target. On this report, we were logged as amber because we had a slight, because we knew that we weren't going to hit 40% our target by the end of March. We were still seeing increases in direct payments, our direction of travel, which was positive, but we could see that in that period, we weren't going to hit our ambitious target, 40%, so it was amber. Our second target is the number of clients receiving support from the care market, from providers rated silver or gold. So all our care providers are rated by the council using a variety of measures, including their Care Quality Commission measure that gives an overall blended score of bronze, silver or gold. Those were the categories citizens preferred as indicators. At the time of this measure, our status was green. We still have more than 75% of the market in that category, but had a slight drop because one of our biggest providers had a drop in their CQC performance. For long-term admissions, this is a quarterly measure, and again, that measure, we were exceeding performance. It wasn't collected as some of the measures were temporarily postponed during COVID, because the way the system operated in COVID was very different in full emergency mode. But our number of residents admitted to long-term care, for this measure, being under target is more positive, because the aim is to support people in their own home. So we were performing well above our target at Q2 of 516 people per 100,000 in long-term care. Again, very positive measure nationally. So although we didn't have that figure for this report, my understanding is it continues to be positive, and it is one of the measures going forward, you'll see. Number of people receiving care in their own home, again, that was online. Number of people receiving shared lives. Shared lives is a very particular kind of care we've been trying to increase. We continue to try and increase that. It's where an individual with care needs goes to live in the community in somebody's home, and that person chooses to open their home and share their life as a full-time carer with one of our citizens. Really impacted again during COVID because of the limits on being able to go out, recruit, interview, assess and work with carers to bring them up to speed to be a carer in their own home. Clients reviewed, reassessed within the last 12 months. This measure is one of our poor performing measures. It's an area we have extensive action plans in, but we are well under target. And the reason for that has been twofold. Firstly, we've been carrying a large level of vacancies on our social work and OT workforce. Much of that has been related to poor comparable rates of pay to all our neighbouring authorities. We have excellent training schemes and a workforce who feedback that they really support the model of adult social care, which is really based on making the most of citizens' strength and empowering them, but we couldn't compete on pay. That's been addressed recently through reports which John Williams has taken through Cabinet and scrutiny, I believe, about how we're altering how we financially reward our social workers and OTs to be comparable with neighbours. We've also launched in the last couple of weeks a big national recruitment campaign to help fill the vacancies. Because people who are awaiting review are in a settled care package, they are not as high a priority as somebody leaving hospital or a safeguarding case in the community. So where our capacity is short, and it has been short because of the vacancies, we focus staff into priority activities. So we're not at all comfortable with this performance, doing all we can to improve it, but it is the area where there is least risk from us diverting activity away from. Percentage of safeguardings where individuals' desired outcomes were met. Normally, we're a steady performer on that. Our target is 85%, and we're still at 89%, well above performance target. But we did dip, so obviously we're checking out why that's the case. And similarly, with the measure below on where desired outcomes were met during the inquiry, we're performing well. The social work satisfaction postcards were suspended during COVID, and we're looking now at how we can reinstate that. And in fact, we're doing more work now to engage with citizens and get feedback using a broader range of measures. I'll stop there, Councillor Brown, because those are the key measures that go to scrutiny and go to Cabinet. As I said, page 2 has other measures that relate to some of the wider performance that we report on. And I'm happy to take questions on any of these.
Okay, thanks for that, Maria. Councillor Moore.
Thank you, Chair. I was just slightly concerned about the lack of information regarding safeguarding, particularly as one of the targets is asking the questions what their desired outcome is. I mean, that should be standard practice. The fact that's even a target is worrying in itself, and that should be 100% and we didn't achieve it. I mean, how are we investigating these if we don't even ask them what the desired outcome is? But then it doesn't talk about, like, well, how many safeguarding inquiries do we have? How many of them are found are upheld? How many of those are dismissed? You know, those are really important questions, and particularly if there's any trends that have been identified within safeguarding. So it's just frustrating that none of that information seems to be reported. It just seems to paint a very glossy picture of it, which is great, but very little information to actually reassure us that actually safeguarding is being treated seriously as it should do within adult social care.
Yeah. We do, as the director at Councillor Moore, have, really detailed measures that are reported to the service lead, John Williams, monthly, and also to directorate management team. Corporately, they try and sort of have a smaller set of measures, but if it's helpful to scrutiny, we could ask for our safeguarding leads to present and give a detail of the information we do collect, both to give you sort of an up-to-date position and also check if there is information you would find it helpful to have as a committee on an ongoing basis. So we'd be really happy to do that.
Well, answer some of your concerns, Councillor Moore, if that could be arranged.
Yeah, I mean, I just think safeguarding is perhaps one of the most fundamental things.
Yeah,
so I'm surprised that the two measures are: did we ask them a question, which we should do anyway, and then how many were satisfied. And I accept the second one. I'm just slightly concerned as to why the first one, but there's no information about how many safeguarding inquiries were upheld and that there was an issue, etc. So I think that is a fundamental thing that, as a scrutiny committee, we should be aware of, in my opinion, anyway.
Sorry, I can't see the screen. I'm sorry.
Fiona, have you got a comment to make?
I just wanted to highlight, it's a bit later down on the agenda, but the work programme does include receiving a report from the Adult Safeguarding Board, I think in December. So some of that information may be provided in that report, but I do appreciate that's one report in a large, complicated work programme, and it's much later in the year. But I just wanted to note that.
Yeah.
I think we've got. Before I bring Councillor Pocock in, I want to sort of ask 3 fairly brief questions myself. The first one is regarding point 2 on the proportion of clients receiving support. Now, I understand that one of the main providers there's been an issue with them, and I want to know what support has been provided to help that agency that's been downrated to get themselves back to the standard they should be at. The second point is regarding the number of reviews. There's been a shortfall of reviews for an extended period of time. That's not, this is not a problem that's recently arrived, as I'm sure Councillor Pocock would confirm. So I am concerned that we don't appear to be moving forward with the review issue. And then the third point was regarding the shared lives. We've got this 140 target, and we've been between 103 and 106 for an extended period of time. And I'm just wondering whether actually 140 is possibly an unachievable target for us. So thank you.
Thank you, Councillor Brown. With regards to the first matter, the support to the provider, the way our commissioning team operate is all providers have a named commissioner. That commissioner goes in and reviews their performance and quality and works with them to do an improvement plan if their performance is dropping, either in our view as a council, because we get more feedback than just CQC, we also visit them. So they will have a comprehensive improvement plan in place with that provider to address those performance concerns. And part of the contract does actually include that if the provider doesn't come up to the required standard within a given period, then we do actually have measures whereby, reluctant as we would be, we would move clients or give them the option to be moved to a higher quality provider. But usually we're working with the provider and able to resolve those issues. On the second one, reviews, you're right, it's been on here as an issue of concern for an extended period throughout COVID, and we've had repeated waves of COVID, as you'll know, including winter just gone. That is the area we have deprioritised. Now that we've got the recruitment campaign in, and also we're hoping to see less staff leave and retain more staff due to the changes in rewards, that I know John Williams is focusing on as one of his target areas to improve. But it is the area where we feel there's least risk to clients. So it is the area that we will divert activity away from, because as you know, Councillor Brown, when we're dealing with high volumes of safeguarding or urgent referrals for people without care, we do prioritise those. The third one around shared lives, yes, I think that measure's been reviewed for the next year's measure. We're not really sure it's a good indicator of performance across social care in any way, really. It was a particular area that we were asked to include when these reports were being done, but I'm not sure it's a good benchmark of performance, and it isn't yet at the moment an achievable target.
Thank you. I know you've got a bit of a time crunch. Could I ask Councillor Pocock to ask a brief question?
Yeah, certainly.
It's a very quick one, hopefully.
Hi, Councillor Pocock.
Right. And I mentioned earlier that we need a new indicator which measures the number of people like the residents I cited who are discharged but without actually any care provided or an assessment. Is that going to be feasible for us to create that? And just a quick one while I'm on. Number of these indicators are benchmarkable and we can get constituency data. I think we did agree, maybe Fiona can clarify this, that once every year we would have a full kind of stock take of the whole kind of landscape with that level of detail reported to us annually. Do we have a programme somewhere that will give that extra detail?
With regard to the discharge measure, apologies, I can't see who's still on the call. Is Andrew still on the call? No.
No, I think yes, he's come live now. So can you answer that, Andrew?
Sorry, Andrew.
Sorry, so we don't have a number, Chair, but it is something that we could look to try to capture.
Okay.
Yes, if you could do that and then sort of let Gail and Fiona know how we're progressing with that, that would be appreciated, I think, by the committee.
Thank you, will do.
Okay, thank you.
And on full constituency measure, I'm sure we can get that data, and when we have the you'll see the new reporting next time. If you want to work with us and Gail, Councillor Brown, to set a time scale for a sort of constituency level, I think it's by our 10 localities that we break data down to, but we can certainly provide data to that level as you're asking on an annual basis. Happy to work with the committee to do that.
If Gail can have a conversation with you in terms of actually moving that forward, I think that would be really beneficial for the committee. Now, I think you need to be going now, so can I thank yourself and Andrew for your contributions this morning.
Thank you very much. Thank you.
Okay, thank you. I think the next item we got is number 10, which is the Healthwatch Birmingham annual report. And we've got Andy Caves, the Chief Executive Healthwatch, is joining us. And he's going to present to the item. And I think seeing Andy, if you can sort of look at measuring issues regarding access to dentistry, day services, and highlights of the access to GP services investigation.
Yes, thank you, Councillor Brown. I'll start off with in the pack was annual report. So we'll start off pulling out the highlights from that. But yeah, in particular, I'm going to focus in on the two investigations. There's one around access to NHS dentistry and the day services investigation that we've done. Members would have seen a GP access report that was circulated a couple of weeks ago now, so happy to take questions on that, but in particular focusing on the other two reports, because I understand that you have a GP access session coming up, so we can happily be part of that as well if you wish us to be so. So I'll just share my screen for you, bear with me. So the annual report covers the year 2021 to 2022. Hopefully you can see that now. This for members new to our reporting, this we just coming to the end of year 3 of our contract, which was initially awarded to us in August 2019. The contract is a 3+2 year contract, so we'll be going into the 2-year extension next month for this. So the contract value is just over 400,000. And within the Birmingham part of us as an organisation, there's 10 staff that are involved in that area of the contract, and we currently have roughly around 25 volunteers that support us within that contract too. So just to give you a summary of some of the key targets that we've achieved in this year. So just over 8,000 people shared their experiences of health and social care for us. With us, we cover all areas of health and social care, so primary care, GPs, pharmacy, opticians, secondary care, mental health services, community services, then on the local authority side, social care, public health. So there's a whole range of services that we are looking at, and actually, in the majority of the engagement work we do, we are very much focused on hearing what members of the public want to tell us about. So we're very much publicly led in everything that we do. Within every intervention that we have, every piece of experience that we hear, there's an opportunity for us to provide information and signposting support to that individual as well. And across all of our routes, which does include our website, information route on our website as well, just under 5,500 people receive some form of information or signposting from us in this period. From everything that we hear from individuals, we do have a prioritisation process, and every year we are targeted to publish 4 reports. Our investigation reports that are specifically on topics prioritised from what we hear from the public. In this reporting period, and I'll give you some more details on it, the most popular report that we published in this period of time was a report around young people's mental health, and I'll give you some of the key findings around that later on in the presentation. So really in the annual report, we've broken down the year as well with some of the key performance highlights for us. In particular, I want to just highlight our work around the vaccine, the COVID-19 vaccine. We're really pleased to have chaired a working group in partnership with the CCG, as was in West Birmingham, Public Health, the BVSC, and the voluntary sector, really looking at how we can improve communication and uptake of the vaccine, particularly through that lens of vaccine hesitancy and inequality around the vaccine as well. We were really pleased to be able to pull some money down from the CCG and get that to grassroots organisations for innovative ways of engaging people around the vaccine. And there was some really exciting things that happened in West Birmingham. In fact, one of the groups even did some canoe trips down the canal to get to the vaccination site to encourage people to do it. So there's some real innovative things that happened as a result of that work. And we were also pleased to have led some community engagement activity in partnership with Birmingham City Council around neighbourhood integration and what that means for people and how services come together within neighbourhoods for the interest of local citizens. That was a well-attended event, and actually neighbourhood integration is a central part of the integrated care system moving forward as well. A lot of the work that we do naturally is focused on inequality. Actually, people's experience is at the heart of tackling inequality for us as a city. We published a report in the year before this annual report covers it, around the inequalities faced by local Somali communities. As a result of that work, we did a number of different activities with the major trusts. So we've done different videos with the Black Country and West Birmingham CCG. We've worked with the Women and Children's Hospital to develop key roles around tackling inequality with them. And we've worked with UHB as well to develop some health literacy tools for them, especially around Dementia. So there's a lot. I think the key thing from that is actually we don't just stop at that reporting process. So when we do an investigation report, the key is the change that we can influence based on that public experience. Therefore, we always do a follow-up report, an impact report, which outlines the changes that have actually been made. And a lot of the time, the life of our reports goes on much longer than that 6-month period as well. So it's just demonstrating there that a report that we published 18 months ago is still having traction today, and changes happening as a result of that report. So information and signposting service. So this really is fundamentally how we can help and support people to access information about health and social care, and how we can help them to navigate what is a very complex system, but also help and support people to do through the complaint system as well. And we work very closely with Power and the advocacy service around the NHS complaint system as well within that. So just to highlight 2 areas that we did a lot of work on, really. So I'm going to cover NHS dentistry in a bit more detail, but we supported an awful lot of people in the last 18 months around accessing NHS dentistry and helping them to try and find a local dentist, which has resulted in our investigation as well. And naturally, in this period of time, we supported people around accessing the COVID-19 vaccination programme and finding local vaccination sites for individuals and encouraging them to uptake the vaccine. The information and signposting service, actually, people can access that in a range of ways. So there's a lot of online access through email and our website contact. There's our information route on our website, which takes through different services and signposting, so people can actually find the information themselves. We do an awful lot though around on a telephone service, and we do receive a high level of calls where we're able to go into a bit more detail with individuals and explore the services that they need to support them. What we're always focused on is that holistic approach. So it's not just about health and social care services specifically, but we signpost and link people with community services as well, which can help and support them. So through everything we hear, we prioritise 4 topics per year. In this period, I'm going to take you through two of our reports that we published in this period. One is around young people's mental health, which I'll go through first. And the other one is around vision enablement services with Birmingham City Council. So in particular for naturally through the pandemic, we heard a lot about mental health services, access to mental health services, demand for mental health services increased, and in particular the concern around young people and getting the help and support that they need was central to everything that we're hearing. So we did prioritise our report looking at the people's experience of Forward Thinking Birmingham. And actually 82% of the young people that took part in our survey and the work that we did said that the support did not match their needs. So the work of Forward Thinking Birmingham was not meeting their needs. And that was from just over 200 young people, their parents and their carers who took part in this investigation with us. A lot of the feedback was around the delayed access. So from being referred or self-referred into the service, that there was a long delay for them to actually get the help and support that they need. The feedback was around actually how individuals at the time of referral to actually getting the help and support deteriorated quite a lot, and actually found that they only got the support when they hit the crisis point rather than that preventative measure of getting help early throughout this. So we've been working closely with Forward Thinking Birmingham around what changes can be put into place, in particular around improving the communication with patients while they wait, the support mechanisms, how they can implement things around self-care to prevent people from deteriorating. And there's just a quote there just from Forward Thinking Birmingham about how they're using the feedback that we heard. Just to say, in the next couple of weeks, we will be publishing an impact report from this. So we've been tracking the changes that have actually been taken by Forward Thinking Birmingham, and that will be coming out in the next couple of weeks, and members will be on the distribution list for that report, so you will receive it. Another area really around services for visual impairment and the rehabilitation officers. Actually, we really focused in on this. We were told by people with visual impairment that actually there is a lack of access to specialist visual impairment rehabilitation officers in the city. There's confusion for them about who to contact, who's there to support them. The registration process and referral routes are complicated, and assessment fails to take into account the other issues. So it's very much focused on visual impairment, but doesn't look at the full needs of that individual within those assessments. And they felt that it was quite impersonal and the support does not consider their individual needs. So we've been working with the City Council and the visual impairment rehabilitation officers, and we're pleased to say that actually that there are new rehabilitation officers been recruited as a result. The information and accessibility and the way that they support individuals has improved, and the team are ensuring that they are in regular contact with individuals. Everybody that is on the sight loss register is getting a regular check-in now. And in particular, we've gone back in as part of the impact report, talked to the people that were involved in the initial interviews with us, and one service user has seen the change as a result of this work, and has found that the service has improved for them and they've got the help and support that they needed through this. So just to focus in a little bit, our volunteers are really important to us. Naturally, over the pandemic, like everybody else, everything went online. Our volunteers really are the heart of what we do in communities, getting out and talking to people. So we didn't utilise our volunteers as much when we were working online, but they stuck up with us throughout the pandemic. A lot of them went and did other activities within their local communities, but they have come back to us now with we're out in communities again through community engagement. As mentioned, we have roughly around 25 volunteers across the city, and that's it, and we're currently recruiting now to increase that number. They really are the eyes and ears of us in communities, talking to people, building trust within communities, and really listening to what individuals have to say. Our volunteers as well get an awful lot, full range of different volunteers, from university graduates in research right through to community members that really want to put something back, to people with lived experiences of services themselves that really want to help and try and improve things. So we're really proud of our volunteer pool, and that's increasing all the time, and we can't do our work without them. So a huge thank you to them. So that's really the highlights of the annual report for you. What I want to do is just focus on 3 key areas. So since April that report was up to, what have we been doing since? So as one of our priorities for this contractual year was around looking at day opportunities. So as members will be aware, this changed a lot during the pandemic, where people weren't be able to get the help and support they needed from day services, and different interventions were put into place by Birmingham City Council. And the members will also be fully aware that actually the day opportunities strategy and everything in the pathway that has been on, it's a really important topic for us to understand the users of day services and how important these centres are for them. So just to give you a few of the highlights from this. So 147 users of day opportunities took part in this through a range of surveys, and we visited a lot of the centres as well to talk to people directly and their carers. 76% of the respondents using day services said that they access it to reduce their social isolation, and that 65% of them actually see the day opportunities centres it actually improves their health and well-being. However, more than 3/5 of the respondents said that there are no other services in the community that they felt would meet their needs, and 55% of the respondents said it's very difficult for them to find alternative services if the centres aren't running. There's a number of improvements that we've been working with the City Council on through this. So actually there's a real need to increase the variety of activities that take place in centres across the city. There was calls for day opportunity services to increase support for young people as well, improve communication. This was a key area that comes up as well for individuals, and improved access to social workers through the day opportunity services came through as well. We're working with the team at the City Council. Won't read all of this out, but this is the statement from Birmingham City Council. The key thing is the findings from this will be used to shape and included in the development of the new strategy, and the team are going out to do an independent review of day services, and that work will take place in 2022. So we'll be continuously working with the team on that new strategy and the development of that, and ensure that the findings that were in our report is used as part of that. The report is going through the internal processes at the moment at the City Council, but it will be published in the next couple of weeks before the end of July. So again, members will see this report in its full detail to get the information required. And then just to focus in lastly on access to dentistry. I'm sure you hear from your constituents all the time the issues with dental care and trying to access NHS dentistry. It is a national issue. However, we found it really important that we needed to understand what was going on locally. Because these services are commissioned on a regional level, we did the report across the Birmingham and Solihull footprint to see whether there was differences across the 2 areas. In total, over 800 local residents took part in this investigation. Really, the areas that came through that actually there's a real lack of clarity of information around NHS dental capacity. What really came through for me was that the first thing when you try to access a dentist is they ask you whether you're registered with that dental practice. The guidance from NHS England say that you don't have to be registered with a dental practice to access NHS dentistry, and you could just turn up. So there's a real mismatch there on what the pathway should be and what patients are experiencing when they're trying to register with dental practices. One of the other things that really came through as well is individuals have been automatically deregistered from the dental lists because they haven't accessed for 2 years. But they haven't been able to access for 2 years because of the pandemic. So there's a real fail in there of an automatic system deregistering people and people not being able to re-register. And we know that there's huge issues as well around actually the dental capacity, a reduction in staff with working in this field as well. So we've been working with the NHS England and Improvement with the dental commissionings team at the Midlands level. We've also been working with the local dental committees for Birmingham and Solihull, who have been working with us on this to try and improve things. So there's a full review of NHS dental capacity taking place at a regional level to identify areas of high need and where the gaps are for individuals. They're committed to better communication with patients to understand actually what their rights are when accessing with dental practices, and eradicating the claims that NHS patients would be welcomed when actually the dental practices are just providing private appointments. What's at the heart of this for me is the real inequality and the deprived areas of our city. Actually, those that can afford care will pay for it. Those that can't go without. And actually, there's real issues around people not accessing the help and support that they need, or going for far too long with dental issues, which has huge impacts. Actually, dental pain is one of the most horrific pains, isn't it? And so actually the effect on your mental health during this as well is huge. And people are going to A&E because they can't get the help and support that they need through their local dentist as well. So there's a real big knock-on effect through this. Again, that report is actually being published today, so you'll see the full report as well, and that will be sent to you. And the final bit, I just wanted to do a little bit about the integrated care system, what our place is on this. So just for members' awareness, we were successful and was awarded the Healthwatch Solihull contract as well in 2020. We see the huge benefit of us having that Birmingham and Solihull footprint to work at that system level. So we do hold the contract for both Birmingham and Solihull now, which means that actually we can position ourselves fully to have the best influence at that integrated care system level. We're very pleased to have a statutory membership of the Integrated Care Partnership that's currently meeting now. So our chair, Richard Burden, is attending that meeting today. We also have secured a non-voting member of the Integrated Care Board as well, so we're fully within that system, and we secured our place to work at the Birmingham place and the Solihull place as well. And we linked in with the inequalities work stream, which is a vital part of our work of the people and community strategy, and within the quality structures of the ICS system. And we're fully committed to utilising those positions to really hold the ICS to account for true engagement and involvement from Birmingham residents, Birmingham and Solihull residents, and holding them to account for the principles of engagement that's within the people and community strategy as well. So that's everything that I wanted to cover today. So I will open that up to questions, Chair.
Okay, thank you for that presentation, Andy. It was really concise, so thank you very much. Members' questions. Does anybody have anything? Councillor Pocock.
Yes, thanks, Chair, and thanks, Andy. Excellent report. Some really useful stuff. And just flagging a couple of items. Day opportunities. I think our committee is due to have some form of informal discussion with John Williams about the emerging strategy. I think your report, when it comes out in a couple of weeks, I think you said, is going to be really crucial evidence for us to be able to pursue in that discussion. So I just wanted to flag that up, and obviously for officers to highlight that too, for us as a sort of essential read before we get, I think it's early autumn, we're due to speak to John about this. Secondly, dentistry, NHS dentistry. I thought you had it in a lovely phrase there, where we've ended up, those who can afford it can't pay for it, and those who can't afford it go without. That, in a nutshell, is the crisis that we've hit. And I think the kind of comments that I sort of picked up informally from the dental practitioners is we don't really want to do NHS dentistry. We're independent practitioners, so if we don't want to do it, we don't want to do it. It's like a walkout of the dentist profession from NHS dentistry. I don't know whether you're in a position to be able to comment on that perception amongst the providers, and maybe take us on some journey as to how we can counter that. Because clearly this goes back to the whole essence of contracting independent practitioners to deliver NHS care when they're increasingly reluctant to want to bother. How do we get around that problem?
Yeah, and I think
2 minutes to solve the problem.
As it's an informal meeting, I think I'll be a bit freer with my my language. Actually, we had some real useful conversations, especially with the local dental councils, to really get the perception of what's going on locally for local dentists. And there really is a huge, there's loads of people leaving dentistry at the moment. The key issue for them is when you look at the NHS dentistry contract, actually that is a very outdated and under-resourced contract that hasn't been improved or increased funding with for a very long time. So actually that conversation, I believe, is happening, and hopefully we'll get some change there, because actually if the delivery of NHS dentistry isn't resourced appropriately, then naturally these private businesses will make their money elsewhere. And that's the crux of it, isn't it? So within this, we have provided all the information that we can at a national level with Healthwatch England. They are having detailed national conversations about changing the dentistry contract and trying to sort it out there. And there have been some a recent Healthwatch England report on dentistry as well, which looks at that in a bit more detail. So I will circulate that as well for members, the national report as well, because it gives a different flavour to actually looking at those specific contractual issues with dentistry as well.
Okay, can I ask you a quick follow-on question to Rob's question, Andy?
Yeah.
And that was, I think there's as you indicate, there's a clear mismatch between the formal pathway and the patient's perception of what goes on. And I know a number of patients who have almost got this perception from the ether that dentistry is now a private issue, and if you can't afford to pay for it privately, effectively you're not going to get it. You obviously touched on the point that the contract's a major issue in terms of that particular problem. How do you see that being resolved, and what commitment is there going to be nationally in terms of reviewing that particular contract? Because my view is, unless the contract's actually renewed and renovated, the situation's just going to continue as it actually is.
Yeah. So really, that's the work of Healthwatch England at the moment, and we're supporting them as much as possible to ensure that they have the experience from Birmingham and Solihull as part of their thinking there. And they are working with central government on changing that, and NHS England an improvement around the commissioning. I think what the potential opportunity is at a local level is that the commissioning of dental services will be coming to the Birmingham and Solihull ICS system in April next year. So I think the influence that we can have locally to try and change this will be improved in April next year. I think there's 11 integrated care systems nationally that are piloting having that for commissioning duty for dentistry at the moment, to see how that can improve. So there's a pilot happening. So it's we're touching base at a national level, seeing how that's going, working with colleagues across England. But actually, there is a real opportunity. April next year seems a long time away, though, when we're in the position of the dental services not being around at this moment in time. Yeah.
Okay. And then the other point I was interested in on page 12 in your report about helping people to get an NHS dentist. I wasn't aware that that system where there was an NHS customer contact point. So
yes.
I'm just wondering how much that's actually publicised. So I'm just wondering whether it's a service that exists, it's not publicised, and therefore it's not taken up. How is that perception I've just explained a correct one?
Yeah, I think the awareness of services like that, we were really challenged through our information and signposting line, actually, but on the NHS websites, where local Healthwatch is the place for people to go to find a local dentist. We really can't do that. It's really hard to do it. So actually us discovering the different pathways to try and help and support people. There is that perception, though, that actually it's just not available for individuals. They've been deregistered, they can't register. You need to put in an awful lot of time and effort to phone around local practices, and probably have to travel when you're lucky enough to find a dentist as well, which isn't it's just not possible for some of our local communities to do so. So very much working at that. We're doing as much work as we can locally with our own comms mechanisms, and that kind of pathway to find a local dentist is on our website as well, and we try and do everything that we can. So it's published today, our report on dentistry. We're working with the press as well, so hopefully we'll be able to get some good media coverage on this to try and increase awareness of the issues locally and how people can find a dentist too.
Okay, thank you for that, Andy. Councillor Moore.
Thank you, Chair. I was going to touch on whether there was, whilst clearly there are capacity issues within dentistry, whether it is there is this perception that you just can't access services. I don't know what the situation is in Birmingham. I've not had real experience of it, but I do know this is a problem in Worcestershire as well. And most of my experience of dealing with dentistry is based on Worcestershire. And I've had many conversations with people adamant that there is nowhere on earth you can get an NHS dentist. But you go on the NHS website, click and find a dentist, and you can bring up a list of people who claim that they're saying that they are accepting NHS dentists. But trying to explain that over the phone to someone who doesn't want to go on the internet and look is really, really difficult. And I think, trying to challenge those perceptional issues is a real issue, and I think that's something we need to. And NHS England as well touched on. They have a resolution team to try and help with this as well, and there's just a lack of awareness of that. And I think, whilst yes, we need to improve capacity, but I think we do need to challenge the message that there is NHS dentistry out there. Yes, okay, you've got to go and find it, and it's not going to fall in your lap as such. But I think we do need to challenge the perception, because otherwise people are just becoming so entrenched in their views. It's really, really difficult to shake that and then get them to get the access, the help that they need with whatever it is dental problems they've got.
Yeah, I agree with that.
In terms of the COVID booster program that you mentioned, I just wondered, were people, I know for myself, I've had the opportunity to get my booster program either through the GP or from pharmacists or through a mass centre. Was there any perception in terms of how people actually preferred to get that? Because I know within some people in the community I represent, there can be a preference not to go to the GP if possible. I just wondered what the overall figure was that you were finding in terms of how people preferred to get that. Did they find it more convenient to drop into the pharmacist, or if there's a mass event going on, say in the city centre, I'll drop down to actually get my jab done then? Yeah,
I think the easiest answer to that is there's huge variation of where people prefer to go. The real key thing that we found is actually whether it was a GP or a pharmacy or a mass vaccination centre, when they had a presence in local communities and a relationship with their local community, they became the preferred place to go. So actually having that real link between the community groups that we worked with and the local GP or the local pharmacy really helped that, and doing talks where actually the GP was visible or the pharmacist was visible to community groups really increased the confidence and trust really for people to arrive. But I think the best thing about the vaccination programme is that it was a hugely varied approach to it, where there was from the mass vaccination places to community pharmacies and GPs to actually the mobile van as well. So actually it was as easy as possible for people when they chose to have the vaccine to go and do it, and there was a range of options for them, which we were pleased about.
Okay, thank you. Councillor Pritchard. Councillor Pritchard, are you okay?
Yeah, sorry, yeah, thank you, Chair. Going back to this opportunity, as you put it, around dentistry and bringing that into the Birmingham Solihull ICS, or at least partly, I'm just wondering how much actual latitude will that give the local system? Because it sounds to me like the contracts are still going to be kind of determined nationally. So how much will the Birmingham Solihull ICS be able to vary those, adapt those, and kind of negotiate locally in that way? Because if it's a central contract that's kind of agreed, and then you can't do much with it, even if it's kind of brought into your remit, you can't do a lot with it. However, if you are able to change bits or tweak bits quite a bit, then that does offer more wiggle room. So yeah, I was just trying to get a sense of how much in reality there will be that ability to I suppose negotiate locally if needed. Yeah,
and a caveat my response with, I'm not an expert on this at all, but I think the example that we can look at is actually the way it works with primary medical services. Actually, that is a national laid down contract. So locally, the local commissioning route can't change that. However, there's add-ons to that contract that you can put in locally. So I expect it will take the form of that actually there'll be the standardized contract locally where there's increased need or areas of work that we want to commission locally, then that can be put in place on top of the national contract then.
Have you got a follow-on question on that, Councillor Pritchard, or are you okay with that response?
No, yeah, that's helpful. Thank you.
Okay, thank you. Has anybody else got any questions to ask Andy while we've actually got him here? Can I ask one additional question then, Andy? In terms of day service provision, obviously it was severely impacted by the pandemic with centres being closed. I'm just wondering, in terms of carers, for people who were looking for somebody who would have been going to daycare provision, what support did they feel they got from the social services in terms of the fact that we know I know my cared for can't go to this particular centre, but do I feel supported as a carer during that particular time?
Yeah, I think to answer that, I kind of reflect on the journey that we went through in the pandemic. Actually, through what we heard from carers that normally access these services is actually in the early stages of the pandemic, communication was really poor, and they did feel that it was a little bit abandoned during that period of time. As the pandemic and lockdown in particular continued, actually the pressure on caring for individuals increased. We did raise that as an area for Birmingham City Council to look at, and we were informed that actually increased telephone communication took place with carers in particular to make sure that they were being their needs were being looked after, as well as the individual with the care and support needs. In particular, I think that this is the real crucial bit with the review. Throughout the pandemic, different alternative solutions were put in place to day services. We're now in a position where we have those continuing and day centres. And I think that really needs to be looked at as part of that review to make sure that individuals have a range of services, and it's not just individuals accessing that support, but actually their carers as well get the help and support that they need.
Thank you for that. If nobody else has got any follow-on questions, can I thank you, Andy, for your report, which was as precise and as inclusive as ever, and thank you for answering the questions.
Thank you, everyone.
Thank you. Okay, the next item we got is the work programme. I think the first thing to say is we've had a consultation on a dementia strategy, which was sadly too late to include to include in the agenda for this meeting, but it has been circulated to members for comments. I think the timescale to get it back is not a great one, but I would really appreciate if members could actually make some comments, forward them through. And I think we may want to consider requesting a report at a future meeting on the outcome of the consultation and the final strategy and action plan. So I think Gail and Fiona, when do we actually send that out to people? Was it in the last 2 or 3 days?
The document was circulated on Friday, and the request has been for comments to be submitted by the end of next Monday, the 25th of July.
Okay, thank you for that, Fiona. Councillor Pocock.
Just a query, one of the officers, probably Gail, will know the answer. I think the HOSC did a dementia review some years ago. I seem to vaguely remember that report when I first got onto the committee. It might be helpful to us, if that is still relevant, for that report to be circulated as well, so that we can see whether our concerns raised at that time are reflected in the new strategy.
Yeah, I think that's a good idea, Councillor Pocock. So could we, Gail and Fiona, could we actually make sure that I think it's about 5 years, 6 years ago now, Rob? If we could actually get that reissued to people, I think that would be beneficial. Right, I think Fiona now is going to update us on the decision of the coordinating committee regarding the inquiries to be taken forward.
Thank you, Chair. So in the report that's been circulated, the 3 inquiries that this committee put forward as proposals for inquiries are attached as Appendix 2. Those were considered by the coordinating committee along with the inquiry proposals from the other scrutiny committees, and it was decided that 2 of those inquiries will go forwards this year. This committee, the Health and Social Care Committee, will lead on the inquiry on children and young people's mental health, and that will be carried out jointly with any members from the Education and Social Care, Children's Social Care Committee that want to be involved in that. The other inquiry that's going to be taken forward is the inquiry that will focus on Commonwealth Games health and wellbeing legacy, but it was decided that will be led by the Commonwealth Games Culture and Physical Activity Scrutiny Committee, but members of this committee will have the opportunity to be involved in that work, in that inquiry. The other 2 inquiries that have been agreed is one that will be led by the Economy and Skills Scrutiny Committee on skills and employment opportunities, making sure that the skills offer in Birmingham is meeting the needs of current and future employers. And the 4th inquiry will be led by the Education and Children's Social Care Overview and Scrutiny Committee on child criminal exploitation, linking that with county lines and knife crime. So those are the 4 inquiries that have been agreed. The other inquiry that this proposal that this committee put forward that hasn't been taken forward as an inquiry was on dementia, but as Councillor Brown, as the chair has just outlined, there is the Dementia Strategy. That isn't going to replace a full inquiry that this committee could do, but there is an opportunity for this committee to highlight issues and link in with that work. So I think that's the update from the committee. I don't know, Chair, if you want me to go on to the next stage or whether you want to take members through the next stage in the membership from the different committees.
Yeah, I'll run through that, Fiona, and then if you want to add any comments, then please feel free to do so.
Thank you.
So I think at this stage, members who are looking for expressions of interest to be a member of a task and finish group on either the Children and Young People's Mental Health Inquiry or the Commonwealth Games Health and Wellbeing Legacy Inquiry. Obviously, we want to give members the opportunity to actually have a think about that. There is a bit of a time crunch, so if people could either let myself, Gail or Fiona know, preferably by 5 o'clock on Thursday, I think that would really be appreciated. So I think the coordinating committee can have a look at moving things forward sometime next week. Okay, so I think they're both viable areas of work. I could see people maybe want to be interested in either or both of them. So have a think about it and let me know. I think Councillor Moore, you wanted a question.
Yeah,
I mean,
Chair,
Councillor Hartley.
Any task and finish group presumably will be based on proportionality.
Absolutely, yeah.
Can I say I'd like to be on the mental health one, please?
First volunteer. So you can do. Fiona. You're muted, Fiona. We can't hear you.
Apologies. Sorry, somebody at the meeting had to do it, and it had to be me. Apologies. On the issue of proportionality, that was discussed at the coordinating committee, and I think in principle it was agreed that the task and finish groups could or should be. I think some of the logistics, particularly where there are members from two overview and scrutiny committees wanting to join a task and finish group, I think the underlying principle is of that the task and finish groups will be inclusive, that no political group will be excluded from it, but it might not be possible where members are coming from two different committees to make the numbers absolutely add up to being politically proportional. But my understanding is the principle is that it wouldn't mean that any political group will be excluded from the task and finish groups. So it might be that one group has slightly more representation on a task and finish group than it would do if the numbers were just politically proportional. And also there are issues for the education committee, that there are the co-opted members on the education committee that don't fit in neatly with political representation if that was purely the basis of the membership for the committees.
Yeah, thank you for that clarification, Fiona. But I think at the moment it's just about asking members in terms of to express an interest in areas that they've got a particular personal or professional interest in. So if people could let myself and or Gail and Fiona know by 5 o'clock on Thursday, that would be really appreciated.
And I think, Chair, if Gail will email out to the committee as a reminder, but also for the member who isn't here at the meeting this morning, just to make sure that everybody has that opportunity to express their interest before the end of Thursday.
Yes, I think we're 2 people short today, aren't we? I think Paul Tilsley's not here and Kirsten is not here either, or she's not on my list of people that are here.
Yes. Sorry, it's 2 members. Yeah.
Yeah. So we need to be making sure everybody's got has got that flagged up. I think the next. Has anybody else got any questions on that before we move on to 12 on the proposed dates for the meetings?
Sorry, Chair, I just wanted to flag up in the work programme report. It's actually Appendix 1 sets out the work programme for the committee meetings, and it's just an opportunity for members to review that, to make any suggestions or comments. I think there was a suggestion you made just in the earlier conversation, Chair, about the Dementia Strategy and whether you'd want to include that, or whether members are happy for the Chair and nominated Deputy Chair to look at the work programme in between meetings and make any amendments and bring it back in September.
I'm assuming people have had the opportunity to look at the work programme. Do any members have any comments in terms of what we've actually got detailed in at the moment? No. Okay, well, thank you. That obviously, if people do have concerns in between meetings, to let myself know or Fiona and Gail, and we can look at possibly making alterations to the programme. So then item 12 is the proposed dates of meetings for the municipal year 2022 to 2023. So I think those have been issued to people. And I just wanted to make sure people were happy with the dates we've actually got. And then point 13 is requests for call-ins or petitions, etc. Are there any requests for call-in or council action?
None have been received, Chair.
Okay, excellent. Number 14 is, are there any urgent business? No? Okay, thank you. Lastly, authority of chair and officers to act between meetings.
Agreed.
Agreed. Thank you very much for that. Then the next final point is to say the next meeting is going to be on the 20th of September at 10 o'clock in the council house in rooms 3 and 4. Unless we have another heat wave, and we may be repeating this.
Can
I thank you all for your time today, and please make pass comments through in terms of any of being task and finish groups people have got an interest in being involved in. And I hope you have a nice and enjoyable summer holiday. Thank you.
Bye all.